Hello everyone. This session will be about the stomach anatomy. By the end of this session, we will be able to identify the external feature of the stomach, parts of the internal structure of the stomach, relation of the stomach, and also to discuss and to memorize the blood supply, nerve supply of the stomach, lymphatic drainage of the stomach, and to discuss some clinical correlation. External feature of the stomach. The stomach itself is the most dilated part of the alimentary tract or alimentary canal, and it's fixed at both ends, lie under the cover of the lower ribs below the diaphragm. It is intraperitoneal organ completely. As you can see here, this is the stomach. It consists of four parts: cardiac regions, fundus, body, and pyloric antrum. It has two surfaces, anterior surface and posterior surface, and it has two curvature, lesser and greater curvature. It also has two orifices: the cardiac orifice, which is at joint of the esophagus, and pyloric orifice, which is at the part of the joint the duodenum. And at the pyloric orifice is guarded by a sphincter called pyloric sphincter that separates the stomach from small intestine, or mainly the duodenum. This part have a very important clinical correlation. We will discuss later on. As you can see here, this is the fundus, body, antrum, and pylorus. In this picture, you see the pylorus. This on the upper left. This is the pylorus of the stomach. This part is guarded, as I said, by sphincter, pyloric sphincter. And this part, sometimes the child born with this hypertrophied muscle of this area of this sphincter is called congenital pyloric stenosis. When the child is clinically, the child will suffer from some certain type of vomiting that's called projectile vomiting. Projectile vomiting. That indicates that this child is born with a congenital pyloric stenosis. The stomach wall. External peritoneal covering of the stomach, and then the stomach has muscular layer, longitudinal, circular, and oblique, and inside is lined by mucosal lining fold known as rugae or gastric rugae. Is accommodate expansion and filling of the stomach. The mucosa is covered by this type of thick alkaline mucus. Here we can see the very clear the gastric rugae, and the three part of the muscles. You have the oblique one, longitudinal, and circular one in between them. It's also, this is a pyloric part, pyloric sphincter, duodenum, and the curvatures, the two curvatures, greater and lesser curvature. And from outside, as we discussed in the beginning of the histology lectures, and the organs that's found inside the abdominal cavity is covered on outside with the serosa, and inside is then musculosa, and then some mucosa and muscular layer. This is a peritoneal attachment. At the lesser curvature, we have this one is called lesser omentum, and at the greater curvature of the stomach, we have this one is called greater omentum. Relation of the stomach. The anterior wall contact with the diaphragm and anterior abdominal wall, and posterior stomach related to the structure behind the lesser sac is called stomach bed, or structure of the stomach bed. The stomach bed is the left crus of diaphragm, left kidney, left suprarenal, spleen, splenic artery, and pancreas, and also you have transverse mesocolon and transverse colon. These are the structure of the stomach bed. It's found behind the lesser omentum. You should keep this on. As you can see here, we have this pancreas and this one is transverse mesocolon, and here is the transverse colon, and here this is the splenic artery is found above the pancreas. It's curved tortuous one, very important. It is tortuous, found the upper border of the pancreas, and here this is the spleen itself. Here is the left kidney, and here is the left suprarenal gland. Blood supply of the stomach. The stomach is supplied by four sources or arterial sources. We have right gastric artery, left gastric artery, right gastroeploic, left gastroeploic, and short gastric arteries, and drained by corresponding veins into directly either to the left gastric, either to the superior mesenteric vein or to the splenic vein. Let us take a look. Here we have, this is a very large and short trunk, is called celiac trunk. From the celiac trunk we have left gastric, this is celiac trunk, and then we have left gastric artery supply the part of the lesser curvature, and we have this one is a right gastric artery. It is indirect branch of celiac, indirect branch, and this one is a right gastroeploic artery or gastromental artery, and this one is a left gastroeploic artery. This is the branch of splenic artery, and those are the short gastric arteries, also are branch of splenic artery that supply the part of the fundus of the stomach. Here are the corresponding veins. We have right and left gastric vein, left and right gastroeploic vein, and there is a vein we found in anterior to the end to the pylorus, is called pre-pyloric vein. Pre-pyloric vein, this is very important for surgeons. Lymphatic drain, as you can see here, area 1, area 2, area 3. Area 1, the upper two-thirds drain along the right and left gastric vein to celiac lymph node. In area 2, drain along the right gastroeploic vessels to subpyloric node and then to celiac node. In area 3, drain along the short gastric and splenic vessels to suprapancreatic node and then to celiac node. Here we can see the very clear the gastric rugae and the three part of the muscles. We have the innervation of the stomach. Parasympathetic fibers from vagus is responsible for motility and secretion, and that come from two parts. We have anterior and posterior vagal trunk. The anterior one is the left gastric vagal trunk, and posterior one is the right vagal trunk. And also we have sympathetic nerve fibers that originate from the spinal cord segment T6 and T9 that convey vasomotor and convey visceral pain to the stomach. That comes through the greater splenic nerve. You have some clinical importance when someone is suffering from the acid secretion that develop into the ulcer. What type of ulcer, peptic or gastric ulcer? Mainly the gastric ulcer we concern here. We have something that we done in the previously in past is called vagotomy, and we have like 2 type or 3 type of vagotomy. We have selective vagotomy, and we have high selective vagotomy, and we have the usual truncal vagotomy. And that truncal vagotomy, that removal of the main trunk of the vagus nerve at the level of the esophagus, that result in the complete deviation of the stomach from innervation to create this acid secretion. And also we have selective vagotomy that only select a vagal branch that supply the stomach and cut it, spraying the other abdominal organs. And we have also high selective vagotomy. This is related to the special type, mainly the innervation to the parietal cells itself that secrete acid. Only branch that supply the acid producing cells. That's the vagotomy.